What's up, world? Here today, I have Dr. William Bridge, and we're going to be talking about psychosis and some of the stigmas surrounding it. What's up, William?
Hey, Juan, how's it going, man?
Pretty good, man. Thanks for taking some time off and joining us today. Congrats on
be fun.
congrats on your house. Like I told you earlier, it's coming right along. I know you said you're 2 months behind, but I'm sure it's going to be worth it in the end.
Yeah, it'll be good. This might be our last podcast where I'm recording outside of there, so it should be good, man.
Okay, that's good, but I'm kind of going to miss the background on what I'm seeing here a little bit. Well, William, today I wanted to talk about psychosis, and I really wanted to tackle some of the stigma surrounding it, because oftentimes people associate psychosis with clinical diagnoses, and that's not always the case, because psychosis is on a continuum, and that's kind of the way I always saw it. And the more I read the literature, the more I understand that psychosis is on a continuum, and the symptoms of psychosis can be found on various clinical diagnoses. So maybe we should start off by tackling the first stigma, which is the difference between psychosis and different clinical diagnoses, and as well as what is psychosis. So would you like to start off by mentioning something regarding psychosis in regards to those two questions there?
Yeah, for sure, man. So I think the most important starting point is to mention that, just straight off, that psychosis is not a diagnosis, right? This is a manifestation of symptoms that are found within different diagnostic criterias and diagnostic disorders. So, just to kind of run off a list to, further emphasize the point that you can't say, oh, that person's psychotic and that's your diagnosis. Some disorders that can present or have as one of the symptoms psychosis. There is, of course, schizophrenia, which is kind of the we talked about earlier that sometimes people use psychosis and schizophrenia or schizophrenic as synonyms, but they're not, and we're going to talk about why. So schizophrenia, there is dementias that present with psychosis. There is a major depressive disorder that has psychotic features that can actually depression plus psychosis. There is substance-induced psychotic disorder. So you take a hallucinogen and then you have certain types of visual or auditory hallucinations, and it can present as psychosis. So, that is just a quick, rundown of some of the diagnoses that can present with psychosis. In terms of definition of psychosis, so I think of it as an altered sensorium of some sort. And that's a fancy way of saying that, your typical, special senses are altered in some way, where you start taking on a belief system that may not be exactly accurate. So we talk about hallucinations. There's lots of different types of hallucinations. There is auditory, where you hear things that aren't really there. There's visual, where you see things that aren't actually there. There is gustatory, so you can actually, have a taste of something that you shouldn't be tasting. There's olfactory, where you smell things that aren't actually there. So lots of different forms of hallucinations, and that is, kind of one arm of psychosis. So you think about these are things that we add. These are all things that the person didn't have now that they do have. And so it's kind of like an addition to their problem. And then you have another arm, which is, more so like grossly disorganized behavior, so the patient will be doing things that are, out of their, characteristic norms. So, they're, putting all the dishes from the kitchen onto the floor in the middle of the night. And you ask them, well, why did you do that? Well, I didn't want them to fall out while I was sleeping, so it's nothing that doesn't have to be exactly too extreme. I've seen patients that went around their house because there was a belief system, and we'll talk about this next, but there was a belief that these type of spy insects, ants, the government was sending through the outlets into the house. So they went around their whole house and super glued all of the outlets, destroyed, 20, 25 outlets in their house was super. So it's very, very, to the patient, it's as real as you can imagine. But hearing it clinically, it sounds pretty well off from what's usual. And then, the outside of the, grossly disorganized behavior, we also think about delusions. So it's not so much their action, it's not the action of putting the glue in the outlets, it's the beliefs that drove them to do that. So delusions are, a belief in something that is very likely inaccurate, but it's hard to convince a patient that it is inaccurate. So there's paranoid delusions where you think the FBI is out to get you. There's grandiose delusions where no matter what people tell you, you think that you're going to be the next president. So lots of different, ways where we kind of compile these different facets to kind of come up with, is this a psychotic symptom? And then if you have that, then you go to which disorder this is and why.
Holy cow, William, you really broke that down. And I can tell that this is like very fundamental in what you do as a psychiatrist. And we're really going to break what you said down a little bit, but sure. How common is psychosis? And that was kind of like the first question I think I asked. And I looked up here in mentalhealthamerica.net, and it says here exactly quote for quote, one frequently cited statistic is that 1% of the population is diagnosed with schizophrenia in their lifetime. But actually 3.5% of the population experiences psychosis. So like you said, when people are using schizophrenia and psychosis synonymous with each other, that's not necessarily accurate. And I appreciate you tackling that from the get-go. Now, also, just to continue to break it down, I kept reading online, William, because as a clinician myself, I obviously deal with clients that are struggling with the symptoms of psychosis and the delusional thinking. For example, one time I had a client tell me that he felt like his phone was tapped. And when I asked him why, he said it was because some of the lyrics he had been writing down in the notes on his phone were being used by other rappers, right? Mm-hmm. And then he gave me specific examples of how this was happening. And it wasn't necessary. It was a stretch to me, in my reality, it was a stretch what he was saying. But obviously I sat through the session and I was listening to him. I didn't try tackling that situation head on at that moment. But everywhere I look online, it says that psychosis is a brain-based condition that is made better or worse by environmental factors such as drugs and stress. Now, they use the word brain-based disorder, and this is something that I wanted to actually ask you because I wasn't sure. We talk about delusional thinking. Yes, I know that there's a physiological component, which we talked in our first podcast ever about the brain. But delusional thinking, when I think of delusional thinking and beliefs, I think of the mind, the frontal lobe. So if delusional thinking is such a big aspect and a huge part of psychosis, why do they call it a brain-based disorder?
Yeah, that's an interesting way of describing it. I think one thing that is important to emphasize, kind of getting back to the details of it, is that you can meet criteria, or you can call someone as one of their symptoms as being psychosis or psychotic in the absence of any delusions. So they can, let's say, for example, you have a schizophrenic patient, 22-year-old, Caucasian male, presents with new onset auditory hallucinations, and his parents report that he's been taking garbage in and out of the house in the middle of the night, bringing it out to the dumpster, then an hour later going back, getting it out of the dumpster, bringing it back in the house. So now you have, well, here's somebody that has disorganized behavior, right? And somebody that is also reporting auditory hallucinations. And just as an aside, and maybe you should touch on that because it's pretty interesting, when you hear auditory hallucinations, most commonly when somebody is reporting that, and this may be good for you clinically to kind of tease out, is this, an auditory hallucination, or is this somebody's own anxiety and racing thoughts? That's a very important, distinguishing point in psychiatry, because somebody who has severe anxiety will have these racing thoughts, and it's their own voice kind of telling them, gosh, you need to get this done. I can't believe you're falling behind at work. I can't believe you didn't work out this morning. I can't believe you're falling behind in night school. So it can present, but most commonly auditory hallucinations are usually like a vague whispering. It's usually like a mumbling, or somebody with a history of, maybe some significant trauma will hear, whoever abused them's voice. So, it's usually something that's, you're not going to hear, parrots that are chirping and talking. It's just not that clear. So that's a good way to kind of distinguish, is this anxiety? Is this, something that is true auditory hallucinations? Now, tying it back to, a brain disorder. So we're starting to realize that, like, the imaging of, patients with the, these psychotic spectrum disorders, schizophrenia, of course, like your neurocognitive stuff, like dementias, they do have brain changes. So, but it's not to say, I think, it's very important to highlight that if you have a 20-year-old that has their first psychotic break, and you image their brain to make sure this is not a tumor that's causing them to, now be, seeing things that aren't there, you can have a completely psychotic 22-year-old that has a normal brain scan. Usually, if we're talking about a schizophrenic patient, it's going to be, 15, 20 years before you start to see some of the organic brain changes. But it's tied back to, all of the drugs address dopamine in, schizophrenia. So, there is a link to, do you want to reduce the amount of dopamine in a patient to then treat the schizophrenia or the psychosis symptoms? So it is tied to a neurotransmitter, dopamine, but, it's not to say that everybody that has psychosis has a brain disorder.
And thanks for clearing that up, and especially the delusional part. And even myself as a clinician, I used that one example, but you broke it down that psychosis doesn't necessarily equal to delusional thinking, and you gave an example right there. But when we talk about psychosis, the literature breaks it down into 3 portions, and the 3 portions are clinical symptoms, or as others might be able to term it, just symptomatology, then cognitive impairments, and functional impairments, such as their social life. William, when it comes to psychosis, the first part I wanted to get into was clinical symptoms. And you've already talked about some of those, such as delusional and unusual thinking, hallucinations, thought disorder. When it comes, it's easy to get confused, though, and maybe this is something we should talk about with the audience, the difference between delusion and hallucination. And maybe those words we need to be careful in the way we use those words, and I'm talking now to the audience, because hallucinations means almost like a visualization or or auditory, so like something that's not there almost. Delusional is almost thought oriented. And I just want to make sure I clarify that. And William, I need to ask you, am I saying that properly?
Yeah, I think
Yeah.
that, and I know we're going to touch on the positive versus negative, but they're both, you can think of it, they're both, gaining something that the patient at one point did not have, right? So they used to not think that the family was trying to steal all of their money. Now they think that they have. That is a paranoid delusion, right? So it's a belief, but they're not acting on that. It's just them telling you, I think my mom's trying to empty out my checking account, right? So it's a paranoid thought delusion. Sometimes you will say, a patient is, deluded, right? So that's kind of where that delusional comes from. So you have kind of like a watering down of, what one would think is a realistic or, real life scenario type of a situation. So that kind of it goes away with what they're reporting their thoughts are. And then hallucinations, just as you said, you're also gaining something that you didn't once have, right? So it's a positive symptom in the sense that you're now seeing shadows that, are, you think is something, and then turns out that it's just the lamp. Or you're kind of seeing animals. Sometimes I hear a lot of the severe psychotic disorders, people will report seeing very little people in the room, which is, an unusual, but I've heard it maybe 8 or 12 times. I mean, it's pretty common. But animals, shadows is going to be the most common overall. People, just seeing people that aren't there. But I talked a little bit about hearing things, and when it comes to the taste and the smell hallucinations, that's usually, you want to think about a seizure disorder. So that just goes to show that medical conditions such as seizures or delirium, you can have psychosis present with somebody that has completely no psychiatric history.
I'm so sorry. I'm so sorry to interrupt you, William. And I'm almost caught in the middle between continuing with the notes I have, right, and actually just going in to the very interesting stuff. But I think for the sake, so we don't get disorganized, I just want to touch on these small notes, and then I want to ask you about a case in which it's someone I know that for me is the blueprint or the perfect example to talk about when it comes to psychosis. But first just for the audience sake, we separated psychosis into clinical symptoms, cognitive impairment, and functioning. And clinical symptoms is separated into positive symptoms and negative symptoms. The positive symptoms are exaggerations in normal human behavior, human experiences, such as thoughts, sensory experiences that aren't necessarily tied to reality, such as delusions, hallucinations, and thought disorder. But then the negative symptoms is something that you've been touching on, which is loss or withdrawal of qualities that make us emotionally connected. So basically something that affects almost our social functioning. And that includes loss of interest in pleasurable activities, so meaning things that we used to like, we don't want to do them anymore. Lack of motivation for goal-directed behavior. So all of a sudden, they lack motivation for pursuing something. And then stuff such as reduced expression of emotion through face, or like you mentioned, just reduced verbal output. They don't want to talk too much. But the literature presents these two as the main clinical symptoms, positive symptoms and negative symptoms. And I just want to make sure, did I miss anything there?
No, I think that was really good. Definitely that loss of, pleasurable activities that you used to enjoy. So sometimes that the fancy word for that is anhedonia. You've probably heard of that. So it's kind of like your general loss of interest in things that used to be your hobbies, right? So that's very telling, right? And I use that really as almost like a point in the patient's life. You want to talk to these patients about what they want, what they used to enjoy doing. And if that has been lost, you kind of use that as your benchmark for where you want to get them back to with, therapy or medication. So if they've lost interest in swimming, and they used to go 5 times a week, you'll know that that patient is starting to turn around when, they're, first get their gym membership back, and then they're, going to the pool, but not doing laps. And then, so you can kind of, it's very helpful clinically. Yeah, the negative symptoms, just as you put it, these are things that are lost. The only thing that I would add to it, Juan, is that, in psychiatry, we could tell a lot just how a patient appears and looks. So, sometimes when you're talking about some kind of negative characteristics, you'll get like a disheveled type of appearance because you lose the hygienic habits as well. So you can lose like grooming and hygiene as part of a psychotic manifestation. Affect, so how a patient appears. Are they smiling when they come into your office? Is that a brighter affect? Now all of a sudden you're seeing them and now they're flat or blunted. So you kind of lose like almost like a facial expression or emotional tone to voice. So these are things that you can appreciate in a patient without even, really asking them directly. Do you feel like, you're numb? You don't need to ask. You can tell how they're talking. So lots of different ways, because we touched on 4, 5, 6 negative symptoms and how that can present. So very interesting for sure.
And once again, guys, for everyone listening, the negative symptoms is a loss or withdrawal of qualities, while the positive symptoms is an exaggeration. So those are, I think those, I would like for those to be connected, so to understand a little bit better. But now, William, to the second part, because we broke psychosis into 3, and we got through the clinical symptoms, and we just kind of went through it just so people can get an idea of what we're talking about. But the second one we broke it down to was cognitive impairments. And this is the one where we talk about where impairments in attention, working memory, problem solving, and cognitive control. Now, I do want to touch upon in this one in one thing, which is the working memory, which is the memory of, for example, all of a sudden, if I have to say my phone number, it's in my working memory. But what we notice a lot of times with those that are struggling with the symptomatology of psychosis or whatnot is that their working memory tends to be very, very faulty, and almost like as if they can't retrieve information. Has that been your experience, William?
Yeah, and it's a complicated situation because it depends. If you have somebody that, when we talk about somebody presenting with psychotic decompensation, right? So for, let's say they have schizoaffective disorder, and they run out of their medicines, but, on day 2, they have a good family support. So they went in the morning and told one of the family members, I'm starting to, get fearful without reason. They bring them right in and you get them on medicines. There's less than, 3 days without medicines. And, you can miss a lot of the, types of, memory impairments, especially in the more acute stages. But you have somebody that's like acutely psychotic, like let's say they come off their medicine, it's a week and a half before they come in. The patients are going to be having a very hard time answering questions. Like if you ask them, what have your last 2-3 days been? What's your daily routine been? It becomes so complicated because you're not sure if it's probably a combination like everything in medicine, but it's likely the fact that they are acutely psychotic and it's hard for them to interpret what your question actually means to give you a viable answer. So that's part of it. The other part is the brain has almost been stunned by this lack of medicine and this influx of sensory information that is not usual. So they're not able to recall, fine details. Now, the working memory, when you have somebody, usually I see this, the working memory start, to become faulty way down the line in your dementias. So if your long-term memory, I guess we should separate long-term memory from working memory. Working memory is almost those automatic memories, right? If I ask you yourself, whatever, you don't need to think to remember it. But, long-term memories, those stick, in patients. So if you say, where did your family used to go for vacation every summer? I mean, they're able to come up with that even, in your pretty significant dementias. But you start asking them like the shorter term thing, like, if you were to go from your house to the grocery store, that you went to on Tuesday, can you tell me the route you took? And they're having, trouble, like, was that at the grocery store on Tuesday? Which way did I go? Did I come from, another store? Did I go from? So that shorter term memory is a little bit more apparent as being off, if that makes sense.
So if that's the case, though, that part that you said right there, I went to the grocery store, and they arrived home, and all of a sudden they start asking, how did I get there, right? In older individuals, once they start developing the early onset of Alzheimer's, which is a type of dementia, they're going through that phase, right? And as time goes on, it gets a little bit worse and a little bit worse. Is that considered a stage of psychosis? Like, for example, that type, like Alzheimer's, would that be considered that they're going through, once they go into the later stages, or they're starting to experience psychosis, they start saying things that don't make sense, they forget things very easily because their working memory, for example, you might hand them something 3 minutes later, they lose it, or they forgot that you gave it to them, whatever the case is that considered they're experiencing like the psychosis, for example?
So that's a good question. My take on it is I keep memory impairment aside from psychosis in that patient population, just because the most common presentation of psychosis in somebody that is showing us their initial stages of dementia, whether it's Alzheimer's or vascular or Lewy body, there's, numerous types, but is usually, it depends on which one we're talking about, but let's talk most common. Alzheimer's dementia, the initial stage is most commonly, from a psychotic standpoint, will present with changes in personality. And usually it's paranoia, for one reason or the other. So you could have, a couple that's been married for 35, 40 years, where all of a sudden the wife wakes up one morning and she swears that her husband is not being, faithful. And she, it just comes out of nowhere. Somebody that's never accused a family member of stealing anything in their life now believes that they're after the family wedding ring, or the dishes from the great grandparents. So it's just very, very specific, paranoid. But that's what's so sad about the dementias is, I always tell families that it's a diagnosis that steals your personality, which is always hard to take.
Thanks so much for answering that, William, because these are the type of questions. That type of question is very interesting, and I was curious about it, and you very much hit it on the spot. The last aspect of psychosis, because we broke it down into 3 parts again, just for everybody listening: clinical symptoms, cognitive impairments, and functional impairments. And with functional impairments includes the role that you play in everyday life, such as role functioning, for example, job, school, home, community, and social functioning. I guess they kind of go hand in hand, and it's very easy to confuse these these almost like the way they're separating them. But if someone's struggling with the symptoms of psychosis and they have the clinical symptoms, whether it be hallucination, delusion, or like you mentioned earlier, hearing things, whatever the case is, all of a sudden, since they're becoming sometimes very paranoid, they're gonna all of a sudden struggle in not only the personal relationships in their life, right, but also in the way they're operating in their daily life, such as they might not want to go to work because maybe the boss is after them, or they may not want to go outside their house because all of a sudden there's little people out there, or whatever the case is. And I think that's important for the audience to understand, that it's not that someone it's not about being strong-willed. And this is something we've talked about before, William, in our podcast. It's not about that. It's about understanding what's really going on behind it, and it's a brain disorder. So thanks so much, William. I do want to talk about substance use in relation to psychosis, right? And this is something that I wanted to talk about because I wrote down here some of the ways in which psychosis, or the clinical diagnosis in which psychosis can present themselves. And I'm just going to mention a few: schizophrenia, schizophreniform, schizoaffective, delusional disorder, unspecified psychotic. And sometimes you have the disorders such as bipolar disorder that you can diagnose in the DSM with psychotic features, or depression with psychotic features, right? And sometimes I guess we can put PTSD with someone struggling with the symptoms of PTSD can also be considered experiencing a state of psychosis. Before we move on, I don't want to say something that's inaccurate. Is that accurate?
So I think, so I would say that the important part there is that you need to distinguish is usually when people start to believe that there's overlap. So first thing is you need to make sure there's not a separate psychotic disorder, right? You need to make sure that this patient is not, also suffering with severe depression that has psychotic features, right? So if it's just PTSD, that's a different story. But if they have something else, usually when it comes to psychosis, now, when you're talking about a patient with post-traumatic stress disorder, you need to make sure that the hypervigilance, so if somebody that was in active combat and, a car backfires when they're going to get their mail and they all of a sudden think that somebody's shooting at them, that hypervigilance in PTSD, that needs to be separate. Everything's always in a context, right? So if you have somebody that has been in war and around a lot of gunfire, and you're looking at a schizophrenic that thinks that he is going to get shot if he goes to the mailbox, those are two separate scenarios. So I very rarely will see true PTSD present with any sort of psychosis.
Okay. And thanks for clearing that up, because once again, that question is one where it may seem like they're overlapping, but they're separate situations and the context is differently. So thank you for clearing that up, by the way, William. I learned a lot with the podcast with you, man. I really do a lot. But just to continue down the list, that Alzheimer's, I wrote down, borderline personality disorder, and then organic, obviously, such as head injuries and seizures and stuff. But then the last one was substance induced. I don't mean to bypass when I'm mentioning these like they're nothing, like just like if they're feathers blowing through the wind. I have to choose one. If not, we could each technically break each one of these down into hours and hours of talking. So substance, and for the sake of the audience, we're trying to keep this just so they get general information, but substance induced. Okay, so I know a case, right, of one time someone for their birthday, all of a sudden taking a huge amount of shrooms, a huge amount of mushrooms, right? And obviously in the moment when they're taking these mushrooms, they start experiencing symptoms of psychosis. They start almost like hallucinating, delusional thinking, right? And then all of a sudden after that day, I never found them the same. So obviously, this is obviously a personal experience. So substance use, we know, and from our previous podcast, long-term substance use or short-term substance use can have an effect on the brain itself. Brain, guys, means the physical structure of the organ. So it can have a long-term effect. So substance use, William, such as in this case, which is why I always tell people to be careful with these hallucinogen drugs, it can cause long-term consequences involved in delusion and or better put, psychosis. Have you had any experience with that? Not in terms of substance use, but seeing it at the hospital. That's what I'm talking about.
With, you know, where the within the hospital, I just want to make sure I know. So you're within the hospitalizations, you see the psychosis like start, but you didn't see it on the admission, or can you say that again, or
well, that case that I told you about is a personal case from when I was younger. Something I witnessed at a social event one time. Someone consuming a huge amount of hallucinogen. And after that day, I personally never saw that person the same, and other people associated with that event never saw that person the same. And it's almost like that person entered a long-term state of psychosis. That's very possible, right?
Yeah, absolutely. So I think that the biggest thing, and where I've seen it, so I've probably seen that maybe, 15, 20 times, where you have, it doesn't have to be their first time using a substance, but where I'm seeing it are these, like, very, very strong, like I've seen it a few times with some of these stronger strains of marijuana, where, it's a strong, high percentage of THC within the marijuana, but the marijuana is also laced with, angel dust, or, so they think that they're just, smoking marijuana, but, there's, angel dust, or, crystal meth is another. So, you think of it as like a bad trip. There's been people that have used ecstasy one time, and have never been the same functionally, like their friends, close family. Nobody knows them to be as they were before they used. So we don't know why that is. Different people have different amounts of enzymes that metabolize a lot of these drugs. That's why some people can smoke for 50 years and never develop any sign of cancer, because their body's just able to metabolize things differently. Whereas some people will have a 5-year smoking history and have bilateral lung cancer, down the line. So we don't know why that is, but one bad trip with some of these synthetic drugs can completely reverse somebody's ability to function. And
I work, obviously, William, as you know, I work in the substance use field, and I've seen that a lot, actually, where a client remains abstinent from substance use for a period of time. The moment they re-engage in substance use, and especially in these high dosage, right? Because these new vape pens that are coming out, it's not that I'm for or against it, but I've seen it where all of a sudden they start hitting it a couple times, and they enter this state of psychosis where, for example, they're talking to a tree outside the hospital, and the parent is in shock. And that's varies from individual to individual, depending on, like you said, how the physical body's digesting the drug and all this other stuff. But thanks for clearing that up, and especially in that case I was talking about. William, for the sake of time, we need to have a second part, just like all these other ones. And we've talked about soon we're going to start having a second part to some of these podcasts. But just for treatment's sake, and we're not going to get too much into the details, but I was looking up certain type of therapeutic interventions or types of treatment for those struggling with the symptoms of psychosis. And for one, cognitive behavioral therapy, psychoeducation, or maybe, for example, substance use and letting them know what's going on, family therapy, because So when the person is struggling with the symptoms of psychosis, it just doesn't affect the individual. It affects everybody around that person, especially sometimes if it happens early on in onset, like let's say early 20s, the parents and the family don't know what to do and they need help. And obviously receiving resources and just counseling in general. But to your side, antipsychotic medication, I'm sure it's huge to suppress the symptoms of psychosis, right?
Yeah, I mean, really, it's, I think the biggest thing to think about is, you heard me say this before, is first we have to decide, what it is we're treating. If it is a psychosis as a result of acute intoxication or, acute intoxication with, say, amphetamine, so, cocaine-induced psychosis, you're just going to need time, right? So in those patients, of course, you don't want them uncomfortable, but if you can avoid medicines that way, you can. Or maybe it's acute withdrawal, so it's alcohol hallucinosis, right? Somebody withdraws from alcohol and then they start seeing faces on the wall. It's not an uncommon thing. So sometimes you just need time. But if an initial psychotic break of schizophrenia and somebody's brief psychotic disorder, comes into the hospital with, some of the symptoms we talked about, these antipsychotics, whether it's a typical class or atypical, gold standard of care, they work quickly. It's depending on the diagnosis, it's likely going to need to be involved for lifelong, and I know we didn't really get into longevity of, some of these psychotic disorders, but you can, sometimes if you're looking at schizophrenia, depending on what resource you look at, you're talking about a 20, 25-year shortened life expectancy in schizophrenic. So we don't know why exactly that is, because it's not one thing. You're talking about somebody who decompensates and then they're doing high risk disorganized behaviors and activities, wandering into traffic, right? So you have more accidental deaths in these patients. You also, there's a component of suicidal risk because of the, one thing we didn't talk about is command auditory hallucinations. When you hear those voices, but now they're telling you what to do. A lot of times it's a negative connotation, like you're no good, you should consider killing yourself. If you don't jump off that bridge, so-and-so is going to be hurting your family. So very believable, and you can't turn them off. So it's a symptom, causing a shortening of, life expectancy. Very potent medicines that, can cause shortened life expectancy. But also, the organic brain changes, right? So we have structural changes in the brain that we don't know exactly how they contribute to longevity, but it's definitely a factor. So, it's important to implement, because you can have a patient who presented psychotic who then leads a completely normal life just by taking 1 or 2 pills a day, right? And they can function and carry a job and, all those areas, social, occupational, family, maintain a normal life. But you want to use them when you know what you're treating, and got to be upfront about some of the risk and benefits of these treatments.
And just to add, that was great information there. We talked about how substance use and specific drugs may lead to states of psychosis and long-term chronic states of psychosis. But we never talked about how sometimes an individual that's experiencing the symptoms of psychosis may self-medicate and may mask what's really going on by self-medication. So, William, thanks so much for coming on, man, and taking time off. I know you got a lot going on with your beautiful house that's coming along, with your loving best friend, your dog, and Lincoln. And thanks so much, man, for just coming on and talking. I actually learned a lot today, and I actually always learn a lot every time you're on this podcast, and I'm sure the audience as well. Thank you as well, because I saw in some of our podcasts we had 400 views, and that's like a new mark. And I'm glad that a lot of people are viewing the podcast, and hopefully you guys are learning a thing or two. And it's just really a discussion with Dr. William Bridge and myself on specific subjects. So thanks everybody, and thanks William, to you again as well. Okay.
Oh, thank you, man. I enjoyed being here. It's an interesting topic, and we'll continue to kind of develop these and figure out what we're going to do next week.
Thanks, William. See you guys. Hey, William, I just want to let you know, dude, that